Good morning. This is Ann Brazo, or good afternoon or good evening, wherever you may be. I am the founder of MPN Advocacy and Education International. This is our, I think, 22nd webinar that we've hosted this year and have a couple more coming up. But I'd like to thank Dr. Rampal for being with us today from Memorial Sloan Kettering. He's always a wonderful guest and answers so many of your questions. And today we're just going to leave it open to MFPV and ET questions. I already have a list of questions for you. But is there anything you'd like to share with us? You know, Dr. Gerds is going to be joining us later this month and talking about, what happened over the summer. But are there any significant changes or things that you can share with us from your lab, Dr. Rampal?
Yeah, I think that there's so many things to talk about. It's hard to know where to start, and that's great, right? And I think I like to kind of divide things into two things, right? There's all of the new drugs that are in trials, and there's a lot around those at the meetings and in other venues. And then there is what are we actually learning about the disease and the biology of the disease and how it changes over time. Um, and I think that, there's also, a lot of things to talk about there. But one of the things is we are learning more about, I think, how the drugs impact uh, the biology of the disease, right? We know what happens clinically. We can talk about what the responses are, but, is it actually changing the underlying genetics of the disease? And there are, some increasing, I guess, bulk of evidence that is saying that it is heterogeneous, and some patients are having really, nice responses on a molecular level that seem to be correlating with better outcomes, and PV is a great example of this, and others aren't. And that is sort of where we've got to begin to understand how does that actually work, right? Because no matter what we talk about, of all of these drugs that we have, it is very likely that there's going to be a bell curve. There's going to be heterogeneity, and some patients are going to have a phenomenal response, and others are not going to have any response. And we've got to really focus on understanding why that is. I think it's less likely in a disease like PV and ET that are a little bit genetically simpler, where in many cases with drugs that we have, like, ruxolitinib or with the interferons, the majority of people will have a response, and some won't. We've got to figure out why are those folks not having a response. But I think with MF, it's much more heterogeneous, and I think that it really needs to be one of the areas that we focus on. In terms of your question about work that we're doing, work that we're excited about, we've been really focused in the last couple of years at looking at drugs, a group of drugs that are approved for breast cancer, that are called CDK4/6 inhibitors. There's three of them that are FDA approved. One of them, at least one of them, is on the commercials on the TV all the time, like all the other pharmaceutical drugs. But this is actually a drug that we're doing a clinical trial right now in MF patients, where we're giving patients ruxolitinib, and we're adding a drug called abemaciclib, which is, again, FDA approved for the treatment of breast cancer. We're hoping to present that data at ASH this year, but we did a lot of work over the last few years in the lab. It worked really well in our mouse models of myelofibrosis and polycythemia. And what I will share is we are very encouraged by what we're seeing. And I
Can
think,
I ask what types of things you're seeing? I'm very curious because this is fantastic.
yeah, no, we're seeing, the patients that we're treating are patients who have been heavily pretreated with a lot of other drugs, including ruxolitinib. And what we're seeing so far is, in the vast majority of patients, when we add this drug in, number one, it seems to be safe. We're not seeing any new toxicities that are a major concern. But the second thing is we're actually seeing some really nice responses in terms of, spleens and symptoms, the things that we traditionally look at, and even it looks like some changes in the genetics as well. It's early, and I have to emphasize what I'm talking about is very early because it's what we call a phase 1 trial. So it's the first time we're doing this, but we're really encouraged. And in my mind, that maybe opens up a paradigm, right? If this is successful, is can we utilize drugs that are already in existence to treat cancer to repurpose them to treat myelofibrosis, right? And there's a history of this. There's, drugs like thalidomide and lenalidomide have been used for years in myelofibrosis, and they do, have a place, I think, in treating patients with MF. But that may be, a way to get people effective therapies in a rapid manner. So more to come on that, hopefully at ASH. We'll see.
Yeah, and so, segueing into this question, and what are the current trials, or which of the current trials do you see showing promise in MF besides this?
Well, I think there's a lot of early data that has come out for a number of different drugs, and some of them I think may have a pathway, some of them may not. But if we go back to data from ASH a couple of years ago, there was pelabresib, the BET inhibitor that we were very much involved with, which really has shown us that if we just think about the shrinkage of the spleen, it's statistically it's better to use the combination than to use the ruxolitinib alone. Now, does that mean longer term that people will do better? That to me is the key question. And I think that's true with all of these, new drugs. And again, there's a number of drugs. There's imetelstat, there is neftamadlin, there's selinexor, so many new drugs in this space. Obviously, the calreticulin targeted agents. And I think the caution for everybody, right, and for us too, from the investigator side, is we have to have some way of seeing results early. And right now we do that by saying, hey, does the spleen get smaller versus our standard therapies? And that is a good, I think, first test for us to say, is the drug doing something or not? Do people's symptoms get better? Or maybe turning it around, do we not add toxicity? That to me is another early litmus test. But longer term, I think the way we've all got to think about this is, does it really change how people do over time, right? Because it's not just about changing numbers in the short term. It's really about, do we make people live longer and better? That's the goal.
So many questions here, and you're feeding right into these questions. One of which is, we know we have 4 drugs approved by the FDA for specifically for MPNs. And at a recent conference that we held in Charlotte, one of the physicians, the MPN specialist, said they no longer prescribe hydroxyurea.
Mhm.
There is no reason to, and they feel that the other drugs available now are better and more specifically targeted for MPNs. What are your thoughts about that?
I guess I come back to the basic principle, with myelofibrosis. Well, I guess with any disease, the first
Yeah.
question is, what are you trying to achieve? And, for somebody who's got an enlarged spleen or has symptoms, it is very clear to us that the JAK inhibitors are better drugs than hydroxyurea. Does that mean that hydroxyurea has absolutely no place in the treatment of MF? My answer to that is no.
I
The
agree.
reason is that it can be useful for certain things. So one
Yeah.
example is that sometimes when patients have uh, PV or ET that transforms into myelofibrosis, their white blood count will be high or their platelet count will be high. And sometimes even when we put a patient like that on a JAK inhibitor, it doesn't bring down the white count or the platelets enough. So sometimes we add a little bit of hydroxyurea just to control the blood counts. So that would be a specific example where it's useful. Another example is same scenario, somebody who's had PV and they've transitioned into myelofibrosis, but they feel fine. The spleen is really not bothering them, but their white count is high, right? And we know that that correlates with the risk of having a blood clot. Is it reasonable in that case to use hydroxyurea just to get the blood counts under control? My answer is yes. So it's very case dependent, but
Mhm.
the proportion of patients who really need or warrant hydroxyurea, I would say is not large.
Would you say, let's say I'm a new patient that comes to you, and I have whatever the symptoms are that you typically would prescribe HU. Would you prescribe that to a brand new patient that you think, this might work better? One of the 4 um, commercialized drugs for MPN patients.
Yeah, I mean, I think if the issue is really symptoms, then I would definitely go with a JAK inhibitor over
Yeah.
an issue.
Okay. So this question, and I'm so glad this person brought this up about the bleeding in the eyes, because I think I've shared with many people over the years that I live in a cul-de-sac and my neighbor has CLL on one side, on the other side, a PV patient, and she always had issues with her eyes. And the question is, they've checked for glaucoma, it is not glaucoma. And her doctor is saying this is ET and it could be from hydroxyurea.
I've
Your
not
thoughts?
seen hydroxyurea cause bleeding per se. Now, could any of these diseases, ET or PV, cause bleeding? The answer is yes, it can. I mean, and really what can happen is it's actually paradoxical. If the platelets get too high, that can actually cause bleeding, not clotting. And the reason is that clotting factors in the blood have to bind to platelets, and that's what allows them to kind of form the glue that sticks to areas of injury. But if there's too many platelets, they start to act as a sponge and they soak up the clotting factors in the blood. And so when there's actually an injury, there's no glue left to stick the platelets to the injury. And so people bleed when the platelets are too high. So could that be a reason? I've seen a couple of cases of that, where somebody's platelets got really high and they ended up having bleeding in the eye. So that could be a cause.
Okay, next question, and they're flooding in. So can an enlarged spleen cause diarrhea and vomiting? And is there anything to address these symptoms while I wait for insurance to cover Jakafi? So sad.
It's so
It's so
sad.
sad. I'm
It's
sorry you're going through that, whoever you are. And if you have any trouble with your insurance company, let us know because Insight, you'll hear from Insight later, and they do have a program for people who are unable to get their drug. Anyway, the answer to that would be,
Yeah, I mean, when the spleen is enlarged, sometimes people do actually have constipation alternating with diarrhea. It just depends on how large it is. And, we've seen spleens be so large that it's actually compressing the kidneys and the bowel, and that can certainly happen. Sometimes if there's nausea and vomiting, that relates to the spleen pressing on the stomach and causing people's stomach volume to actually decrease, so they can't tolerate as much food. And if they have anything else, reflux, it can kind of trigger this sort of sense of nausea, right? This is a case where, coming back to our discussion about hydroxyurea can shrink the spleen to some degree, right? And so if there really is an issue where it sounds like, unfortunately, this patient is really having symptoms and has to wait for the JAK inhibitor to get approved, could that be a short-term measure to at
mm,
least do something to get the signs of the spleen down a little bit while waiting? That would be reasonable to me.
yeah. So, we've all heard the term watch and wait, and this patient with PV is saying she's on the watch and wait protocol. And there's someone in my family who has CLL who's on the watch and wait um protocol also. And I'm not a physician, as you know, Rajit, but I've been around a long time in this space. And I think my brother would benefit from something. Okay. And this patient is saying, and I know this for a fact because we have patients that have PV that were on watch and wait, and then suddenly they're very sick.
Mhm.
And suddenly they need a huge lots of different treatments and have to go through a lot. So this person is asking, and this is a great question, should I request that I start something now and see how things go? Because, and this is, I have to laugh because Dr. Silver's always the huge proponent for start them early, start them now. What are your thoughts on that?
This is so interesting because that is the treatment paradigm, right? And if you look in the
Yeah.
guidelines, those are the guidelines. And I question that, and others have questioned that. And we've written about this because
Hmm.
essentially what we're saying is let's wait for something bad to happen before we introduce therapy. Does this make any sense? I don't know. I don't think it does. Now, that is a different thing from saying that we have definitive evidence that interviewing early makes a difference. But there are pieces of data that are starting to say this to us, right? If we think about PV as a particular example, there is data that if you start interferon earlier, that you perhaps better able to reduce how much of the JAK2 mutation somebody has. And the data is saying to us that actually may be important. There is data from a randomized trial that was done in Italy that took PV patients who we would otherwise just phlebotomize and watch and wait, and said we're going to give some people Ropeg interferon, we're going to give the rest the traditional phlebotomy. And that trial seemed to indicate that earlier intervention made a difference. Granted, it was a small number of patients, and we don't have a long-term follow-up. So I can't, stand here and say definitively, yes, the evidence supports earlier intervention, but there are hints that it does, right?
Mhm.
And I think we've got to do more studies early on to prove this point, because more advanced disease is not going to respond as well to therapy. We could point to any cancer across the spectrum where this statement would be true. So why are we
Right.
not thinking that way in MPNs? Part of the reason is we don't want to give people unnecessary toxicity. So we really have to begin to understand who are the people who are most likely to progress, and if we intervene early, can we prevent it? Those are the big questions.
And those questions, I'm so glad you also brought that up, because there was a study done, and believe it or not, my son-in-law, who's a geneticist, showed everything to me. He showed me, and it was a study, I think they were Swedish physicians that, and I think one of our companies is looking at it, and that was this way to determine which patients were going to do, first of all, get an MPN, and then what kind of an MPN, and then, I mean, it was fascinating. And so I do think there is research out there, and it's just a matter of capturing all of that information and than bringing it to your lab, and putting it into a process that shows us and helps us. But yeah, it's really, there's so many questions. You know that we host an annual women's program, and that we try to address some very specific issues with women. And I'm starting to hear a lot of feedback from women who are older, like either perimenopause, menopause, or postmenopause. This question is from a menopause person who has ET, and whose hematologist just absolutely doesn't seem to want to go there, doesn't want to help her out with HRT.
Mhm.
And that is a huge question right now. And that huge question is, now we all know that the oral HRTs can be very dangerous, and most doctors I know would never prescribe them. But there are topical things and other things that women with MPN seem to be doing okay on. And so what are your thoughts, and what would you suggest she says to her current hematologist who's not an MPN specialist? Um, I know there's so many factors to Raajit, so I get it if you don't feel comfortable answering that, but what are you doing when a female patient comes to you?
You're exactly right. This is not an uncommon question, right? And so there is data here, and this is data actually that came from the Mayo Clinic. So the issue here is that estrogen can be thrombogenic, and so we are very, very cautious about estrogen
Right,
in women who have MPNs. But with hormone replacement therapy, what happens is that we are replacing the physiologic level of estrogen, whereas when somebody uses hormonal birth control, estrogen containing birth control, that is a supraphysiologic level of
right,
estrogen. It's designed to
right,
sort of prevent. And so, what the data has said from the Mayo Clinic from a number of years ago was that with hormone replacement therapy in women with MPN, there did not seem to be an increased risk of thrombosis. And again, that probably comes back to the idea that you're not giving a super physiologic dose, you're giving a normal physiologic dose of estrogen. Obviously, there's other preparations that can be used depending on what the specific issue is. So it can be used judiciously.
yes, if it's, and again, I'm so glad you're saying this, because our event is coming up very soon in New York on the 26th, and we will be addressing this. And it's interesting, because do you remember Dr. Corey, who had PV, or who had PV converted, had a stem cell transplant, and she's living life large. She's having a ball. But she went to a recent conference last year, and the whole subject was about HRT and cancers. And man, it was fascinating. And so I do think, MPN specialists, all of us, and you got, you physicians especially, it's something so important because there's so many females and so many people, now every day new diagnoses. And just to interject one more thing here before I go on to the next question, whenever we host these webinars, we get between 50 and 60 new patients who sign up for these they may not all be here today, but they sign up and register, and they're new. They're new patients. And so this is pretty fascinating. That's evidence to all of us. It should be evidence to all of us that these blood cancers are everywhere and they are not going away, and there are more and more people being diagnosed.
Absolutely agree.
Okay, I'll be quiet. I'll just ask questions. Are there any new drugs available that address neuropathy?
Neuropathy is complicated. I mean, and it depends on when somebody says that they have a complaint like this, to me, the first question is, what do you mean by that? Tell me more specifically, right? And in some cases, what we're actually dealing with is what's called erythromelalgia, which is due to high platelets, as an example. So what is that? Well, that, sometimes people have burning, tingling in their fingers. And often the simple answer to that is to give them aspirin twice a day.
Yeah.
In many cases, it goes away. But if that's not the issue, could it be a neurologic issue like neuropathy, which is really an issue of the nerves themselves? That requires a further workup because there are so many potential causes of neuropathy. It could be anatomic, it could be a neurological disorder, it could be due to diabetes. There's so many things that could cause neuropathy, right? So the answer to this type of a question, I think, is always what are we actually diagnosing? Are we really
Mhm.
diagnosing a vascular problem that could be MPN related, or are we diagnosing a neuropathy for which we have to go down the assessment of what are the things that could cause that? But there are medications available for neuropathy.
This individual is on Jakafi 10 milligrams down from 15. They are plagued with basal cell and squamous cell is cancer. Is that just something that must be tolerated, or is there any alternative for this patient?
Yeah, no, this is not an uncommon problem. And so there is an increased risk of squamous cell carcinomas with ruxolitinib, which we've known about really from the PV studies. Now, skin cancers are complicated because, if you have a lifetime of sun exposure, could that be the cause? And this is the problem oftentimes when we're dealing with this is it that or is it the Jakafi? And how do you
Mhm.
figure out? And it's a hard thing to figure out. And sometimes the only thing to do is to stop the Jakafi or the ruxolitinib. Um, depending on what the diagnosis is, can you use a different JAK inhibitor? The answer is yes. And the reason is this. Um, Ruxolitinib targets JAK2. We all know about JAK2, but there's also something called JAK1. There's four members of the JAK family, so JAK1 is one of them. What we think is that JAK1 is actually involved in immune regulation, and so ruxolitinib inhibits both JAK2 and JAK1, and we think by virtue of inhibiting JAK1, it allows things like infectious diseases to manifest as well as skin cancers. And so could moving to a more selective JAK inhibitor like fedratinib or pacritinib, which are really more JAK2 focused, alleviate that? Sometimes that's what we end up doing, is switching to one of those drugs just because it doesn't have the JAK1. It's completely empiric because, again, it's hard to prove in a specific patient's case that it is the Jakafi that is doing this, but we do know that it can do this.
Okay, this patient has MF, early MF, atypical CALR mutation, which you're very familiar with, and also needs to begin a biologic for psoriatic arthritis. Any biologics for PSA that should be avoided or have added benefit for MF?
Nothing that I'm aware of that has added benefit for MF. The question about, which drugs to use, that really requires a pharmacy review where we have to look at what the drug is and what the potential, drug for the MPN is and if there's overlap. My experience has been in most cases there isn't. Now, there are things like interferon where sometimes we want to be really judicious about using it in somebody who has an autoimmune condition like a psoriatic arthritis, because in some cases it can make it worse, and that we've known for a long time. But on a drug by drug basis, it just depends on what the specific interactions are.
Okay. This person has MF or PV. If they should develop MF and are not responding to anything that their hematologist tries, can they contact you? I
First,
would say the answer is yes, but for
it,
advice, for
of
advice.
course, the
And
answer is
yeah,
always yes to that question, but also there is nothing that says that that course is inevitable, right? That's
yeah.
not at
Yes,
all.
right. I mean, yes, people convert to MF from ETPV MF, but there's nothing right. I'm glad you said that. All right. So, this person has PV and CLL. Is there anything different that she should do about monitoring these two blood cancers?
Um, in general, no, and we do see a fair amount of this. I mean, CLL is technically the most common of the leukemias. So it isn't a surprise that we see patients with both. The part of the question is why, and I don't think we have a good answer. I think the only thing to keep in mind is it depends on if a treatment is being prescribed. So, for example, if hydroxyurea were to be prescribed, hydroxyurea does increase the risk of skin cancer, but CLL by itself increases the risk of skin cancer. So one would
Yeah.
want to be, extra judicious about getting regular skin cancer screenings. That would be the sort of the biggest thing I could think of. But
Yeah,
usually,
my brother had a skin cancer last year and it did not heal properly. I mean, he's fine now, but same,
same.
very, very true. CLL patient. Yeah.
Mhm.
All right. If I had moderate high platelets for years and JAK2 positive in 2023 with an ET diagnosis, and now have a higher red blood count, white blood count, HGB and HCT, but still high normal. So started hydroxyurea 500 milligrams a day. Is this scenario considered a patient with ET and PV?
Interesting question. So, the question I would probably ask is, was a bone marrow performed at the
Yeah,
diagnosis, right? Because ET and PV, really, the diagnoses in most cases require a bone marrow. The problem is that early ET could look like PV, or sorry, early PV could look like ET based on just blood counts. There is something called masked PV, in which people's hematocrit doesn't rise to the usual level of what we would require for PV, but their bone marrow looks like PV. And in those cases, sometimes the patient is iron deficient, and so their blood counts don't get high enough to meet the threshold. And sometimes, as their iron stores replete, the red count goes up, and now we say, whoa, wait, this looks more like PV. There is something called pre-fibrotic myelofibrosis, which is an early myelofibrosis, which that can sometimes look like ET. And what distinguishes it is that the white count sometimes starts to go up. Um, and then there is the sort of relatively rare occurrence of ET actually turning into PV, which is known to occur in about 5% of cases. So, could this have been an ET that has now turned into a PV? The answer is yes, that's possible. Could this have been PV all along that was sort of undetected and now is sort of showing itself? The answer is yes. So there are many potential explanations here. But sometimes what I do see, when we see a referral is they'll say patient has ET and PV, and that can't be
yeah.
the case. It's either one or the other by definition. But sometimes what we're seeing is the evolution of one into the other.
Yeah, because I've heard that a lot. Since ET can be caused by acquired mutations, is there enough work being done to investigate what is causing these acquired mutations? Environmental factors, chemical exposure, prior meds, inflammatory insult. Great question.
It's a great question.
Yeah.
Without I think without question, the number one question patients ask that almost, I would say 99% of patients I've ever met who I
Yeah.
meet for the first time ask, how did I get this mutation? Almost universally.
Right.
You have a good explanation. I don't think we do. And there is some very interesting work that has come out of the UK, some really nice genomic work that it has demonstrated that the mutation can occur a decade or two before somebody actually has the disease, right? So these can be events that occur really early in somebody's life before somebody actually has a disease. But the question is why? What is the susceptibility? Certain people do have a susceptibility to getting JAK2 mutations, and we've known that for about a decade. There's something in the DNA that makes people a little bit more prone. But the way I think of it is that there has to be a susceptibility, but then there has to be something that caused the event to occur. It's really difficult, and I want to caution people to go back and think about your life and say, well, it was that summer that I spent repainting the house because I was breathing in paint fumes. Maybe, right? But there's no way to know that for sure. Are there data that have associated toxins with MPNs? Yes, radiation for sure. Paint thinners and solvents.
Benzene.
Agent Orange, right? And we now have
Right.
data finally that has
Yes. And
indicated,
benzene exposure.
and benzene exposure as well, right? So can toxins cause mutations? Absolutely. Have they been associated with MPN? Absolutely, they have.
Hmm. You were such a great resource for us during that time, going to the FDA when we were trying to prove that some MPNs in patients that had been in the Vietnam War and other wars, their exposure to these toxins caused their MPNs. And for some of you that may not know, he came to meetings with me at the FDA or with the VA, I'm sorry. And but then he introduced us to Dr. Tu at Georgetown University, who was able to show that there is a link, and not just for Vietnam vets, but for Korean War and Gulf War veterans. So we rarely get a letter anymore from veterans that say we can't get our claim passed to get help with our benefits. We almost never get. We just got one a couple weeks ago, and that was very few and far between now. So thank you for your help with that.
No, no, my pleasure.
Um,
And I would actually love to know, and I don't know if there's a way to figure this out, we're not hearing from people, but are they actually having success getting, their
yeah, I think so. Yeah, I think they are. And of course you gave us language for a letter for them as well, which was great. So we know, again, we try to identify areas in the MPM world and where there are cohorts of patients that need extra attention or are coming on the scene as new patients and so on. But in this case, young adults and pediatrics and young adults with an MPN. And we did partner with Nicole Cousin at Weill Cornell for the pediatric piece, but she just wrote a paper on the transition from pediatrics to adulthood. And so my question to you is, how are what are you experiencing in the way of numbers of young people coming to you, young adults? And, has that number increased? I'm going to guess it has, but also is there anything different in the way that you treat a young adult to a person perhaps in their 60s, 70s?
So we are seeing a large number of our patients who are, I would say between the age of 20 and 45. Let's just use
Yeah.
the category of young, right? Uh,
Mm-hmm.
I would say it's about 20% of the MPN patients we see, and we see a lot of MPN patients that's
Growing.
suffering. So this is really on some level troublesome because the paradigm has been, well, this is a disease of older people. That's not true. There's a
Right.
large cohort, and Dr. Kuchin, my good friend, specializes in the care of kids with MPNs, right? There is something here that we're not understanding.
Mhm.
Um, and she and I have talked a lot about this, about maybe looking at all of our young patients as a cohort of why are they different? How are they different, right? Because there is something we're not understanding. The care of younger patients is a little bit different, right? Because, one has got to have the perspective of a longitudinal perspective, right? These are people we want to have decades of life
Hmm.
ahead of them. And so coming back to something you were saying earlier, right? Does earlier intervention make sense, right? Because why are we waiting for something really bad to happen to somebody, right? It's becoming more harder for me to convince myself that that's the right approach. So I think being proactive and thinking about this is important. We've got to balance that with toxicities because what we don't want to do is give people unnecessary side effects from medications that are going to make their life more difficult. And we've also got to be cognizant of other things that are different at different stages of life, right? Family planning being a big part of it. It's so important that we talk to our young patients about family planning. What are their, are they planning to have a family? If so, we've got to take that into account in terms of what we may do or may not do from a treatment standpoint, and also to make sure that they are, if, for example, we have a young patient who is planning to start a family, do they have the right care? Are they in a specialized OB-GYN setting where they're going to have access to doctors who practice what's called high risk maternal fetal medicine? That's vital for our MPN patients. They can't really be under the care of a generalist, OB-GYN doc who may not be familiar
Hmm.
with the complications of the disease. So we have to think about our young patients differently.
Yeah. And, I know a young man, he's part of our patient advisory council who, was 15 or 16 when he was diagnosed, and watch him wait, watch him wait, watch him wait. And he got very sick. And, the other question, the caveat to that would be, what would you start a young patient on? And would it be interferon? Again, I have to think of Dr. Silver, but, but I have seen some successful interventions with younger patients with interferon. Is that typically what you would prescribe?
That has generally been our practice, is that interferon has been our go-to for young patients. It is a drug that has decades of data behind it. We do certainly think that it may be able to change the course of the disease in some proportion of patients, right? In a way that other drugs like hydroxyurea can't. So yeah, that has absolutely been our go-to drug for younger patients.
Okay. Over the last 15 months, my TP53 mutations have gone from 6 to 0, but my JAK2 has increased from 50% to 97%. I've been on Besremi for the last 7 months with a small amount of HU to keep my white blood count down until the Besremi fully kicks in. Have you had patients starting with dangerous TP53 and over time was it eliminated?
This is a good question. I know that this raises concern among patients. And so there was a bunch of data that came out at ASH last year. And so here is a situation where we can actually put together some biological data and clinical data. So, we've done a number of studies with mice, and the advantage of mice is that we can change their genetics and observe them. And what we did a number of years ago was to take mice that had a JAK2 mutation, and we knocked out the TP53 gene. Now, let's keep in mind there are two copies of these genes of JAK2 and of the TP53. And the question has been, well, do you need to have something bad happen to both copies of the TP53 gene or just one? So when we do this in mice and we just delete one of the or delete one copy or just mutate one copy, nothing happens. The mice still have PV, their disease doesn't progress. When you damage both copies, then the disease gets very aggressive. Is that true in humans? The answer seems to be yes, in that people who have only one mutated copy of the TP53 gene don't really seem to have a different course in the short term. But the people who have a damage to both copies of it, that's a very different thing. And those patients do tend to have a more aggressive disease. So based on the numbers that were quoted without knowing the rest of it, it sounds like it's
Mm-hmm.
very likely it's just one copy of the TP53 gene that has been affected in this case. So by itself,
Right.
it is not something
Yeah.
that is particularly worrisome, but it is something we have to keep an eye on.
Right. For your PV patients on interferon who have consistent labs and normal ranges, how often do you recommend having labs done?
This is sort of everybody has their own practice. I
Right.
check labs in somebody who's been very stable. I check labs every 3 months or so.
Okay.
But for others,
And
sorry, go ahead.
no, go ahead.
I was going to just say for somebody who's on treatment where we're trying to find the right dose, then it could be every 2 weeks, every 4 weeks. It just
Oh,
depends on where we are with things.
okay. And Rajit, just personally, a question, does insurance pay for all that typically?
For routine blood work, I've never had a problem with insurance
Yeah.
covering it.
But in identifying, like if it has to be done for quite a while, do they seem to pick that up or you don't know?
Usually it hasn't been a problem. I can
Okay.
imagine that it might be because
Yeah,
insurance
yeah,
needs to work, but typically it's not because usually it's clinically justified.
right. Okay, good. This person was diagnosed with ET, JAK2 positive, and their platelet was 600 plus. They are 69 years old and are taking hydroxyurea and aspirin. The hydroxyurea side effects, they had side effects, sorry, I'm trying to read this. And they were told to get off of it for a month. The platelets went up to 800 plus. I'm back on HU, but these are the side effects. I'm worried about progression, but also skin cancer. I've had skin cancer removed 3 times. My consultant says second line of medication is busulfan. Did I pronounce that right?
Mhm.
Busulfan, but it's also chemo, so it worries me. Any suggestions?
Yeah, no, we have a variety of options for patients like this, which is a good thing, is a great thing. There was data presented at the ASCO meeting, which is the big oncology meeting in May, for ropeg interferon exactly in this situation in patients who are having side effects from hydrea. And it was compared to another drug that is FDA approved for ET called inagrelide. And the ropeg interferon actually showed a better efficacy than inagrelide, but inagrelide still does work. So right off the bat, there's two options. There is inagrelide and there is interferon. Ropeg interferon is not yet FDA approved for treating ET, but do we use it off label? We do. So interferon is an option. Inagrelide is an option as well. And I will say that with some of the new JAK inhibitor trials, the new selective JAK inhibitors, they are allowing enrollment of patients with PV and ET who've been on other therapies. So no, there are options. Busulfan is I want to be careful because I never want to second guess the judgment of another physician, particularly when we're talking about a case in this way. But busulfan is something that can be associated with a risk of leukemia. We do use it, and the only rare times we use that drug is in somebody who, let's say, is 89 or 90 years old and wants something very simple to control the blood counts. It's a reasonable thing. But at the age of 69, I would be
Yeah.
reluctant.
And speaking of an agrolide, I trust, given the evidence in the past, I don't know where we're at now, to be honest. But some of the evidence in the past was that, it could be a really tough drug for some patients. So, in terms of heart issues and so on. So how is that prescribed these days? I'm just curious.
We don't use it often, but we do
Yeah,
use it. Sometimes what we end up doing, I mean, you're right. Sometimes it can cause palpitations, but sometimes
heart
what,
attacks.
yeah, and it's not the best tolerated drug always, but sometimes we use a low dose of that plus a little bit of hydroxyurea to kind of get the counts under control, and that way you're sort of not getting major side effects from either drug.
Right. Okay, great. I understand that Jakafi often causes weight gain. We hear this all the time. Is it difficult to control with diet or exercise? If that's true, why not consider using rapamycin or GLP-1 drug to help since each affects society, I can never say this word, fullness in opposing ways.
Yeah, this is not an uncommon problem, right? Um, so the weight gain is a real issue. And in my sense is that, diet and exercise are somewhat helpful, but they don't really make a huge difference in terms of the weight gain. Sometimes it's enough that we have to reduce the dose of the Jakafi or just switch to a different medication, so that happens. But the question of the GLP-1 drugs, the drugs like, Wegovy, which are used really quite broadly these days for weight loss, for diabetes, for all of these types of things, can they be used to some effect? So we do have a fair number of patients who are actually on both. And we have seen some modest weight loss when people are on both medications. So that is a strategy that is being used for sure.
This patient has been on Besremi for 2 years and has seen no change in their blood work. Should they remain on Besremi, or, I mean, 2 years is a while, or should they look into something else?
I guess it depends. It's a little bit of a difficult question to answer in the sense of um, if they're on Bezremi, presumably for PV, does that mean the counts aren't adequately controlled or that they're sort of reasonably controlled? I'm not sure. You know, I guess maybe just broadly speaking, what would the alternatives be? If it's for PV, ruxolitinib could be used instead. That would be a reasonable option. Hydroxyurea could be used instead. So there are options beyond Bezremi, but I'm not entirely clear what the particular issue or side effect is here.
Mhm. Have you seen in terms of numbers of patients recently, are there more ET patients coming to you, more PV patients, more MF patients? What kind of trend are you seeing currently?
I would say all of the above. I mean, I've a lot more PV, I would say,
Yeah,
but certainly a lot of MF, a lot of ET. Yeah, no, everything is increasing, but more PV,
yeah.
would say,
I,
as of
it's
late.
crazy, isn't it?
It's
We have time for just maybe one more question, and I encourage you to stay with us to hear. We only have a few industry partners that are going to give updates, but there's always something very fascinating about, the new drugs in trial, and these are all for you people, every patient, and for the physicians that are hosting the trials and so on. But also, it's just important to know what's going on. But Rajit or Dr. Rampal, respectfully, I adore you. What I always ask our physicians to give us some insights and to give us some hope for the future. Every year, it's just been amazing. But what wisdom would you impart to those who will see this today and who will see this in the coming months, um, for the future of the in the MPN patient world?
to me, the biggest thing is that there is so much happening in such a rapid manner, and that is a good thing. And, I think about the patients that I see with myelofibrosis, for example, where the JAK inhibitor isn't working, and I say to them, well, I have 4 or 5 options for you. I've got all of these clinical trials, and if we were having this conversation 7 years ago, I wouldn't have those options for you, right? And that is a remarkable thing. It's a wonderful thing. But what I worry about, and this is because we get a lot of case patients who are referred in or who self-refer in, is is everybody being treated with the knowledge of where things are currently? The answer is no, right?
No.
There are so many patients who are under the care of physicians who do not specialize in this disease. And let me be abundantly clear, I'm not being critical of those doctors because they take care of colon cancer, breast cancer, pancreas,
Right.
a little bit of MPN. I can't do those things anymore, right? And so that's not a criticism of them, but
Mhm.
what I do want to communicate to our patients is that if you're under the care of somebody who doesn't specialize in this, it is never a bad idea to get an opinion from a specialist at a referral center who does a lot of MPN. It doesn't mean you've got to switch your care because I understand the geography. A lot of people live 2, 3 hours, even more from a place where there is a referral center. But I don't think it's a bad idea to get an opinion from a specialist to make sure that your care is on track and to make sure that you are aware of all of the updates that are going on, right? Of all of the new trials, all of the new data. Part of it you get from being on, these terrific seminars that Anne puts on, or for, things that the MPN Research Foundation does. But, being aware of what is really going on and where the treatment paradigms are, that to me is the most important thing you can do. Empowering yourself is the most important thing you can do. And some of it comes from the education that gets provided online like this. But I think it is also important to make sure that, you have a check-in with a specialist just to make sure that, number one, the diagnosis is correct, and that number two, you're on a treatment plan that is the most beneficial for you as an individual. And again, that doesn't mean you've got to switch doctors, but having somebody else just to kind of look over your case who does this as their major focus, I think is a good thing.
Absolutely. And if you don't know of an MPN specialist in your area, let us know and we'll try to find somebody for you. And then also, if you have trouble with insurance covering that special visit, let us know and we might be able to figure out how to work with your provider. And Raajit, thank you so much. It's always a pleasure. We hope to see you in New York. You can come to our luncheon if you'd like, and I'll send you a message about that. But thank you so very much. And again, stay with us and we're going to hear from 4 industry partners who have some special news for all of you. But thank you, Raajit, very much. Have
And
a
thank
good
you for
day.
this, and thank you for what you do.
You too, buddy. Thank you.
Bye-bye.
So now we're going to hear from our industry updates, or hear our industry updates. And Kristen Griffiths is the first person you'll hear from, who is with Insight. And she's the Associate Director of Communications and Patient Advocacy in the US. Hello, Kristen. Good to see
Hi.
you.
Hi, can you hear me okay?
Yes.
Great, great. Hi, everybody. Thank you so much, Anne and Natalie, for having me. As Anne mentioned, I handle communications and patient advocacy for Insight. And essentially what that means is that for the US, I lead programs and partner on initiatives at Insight that support the MPN community. Including raising awareness of these rare blood cancers and sharing real patient stories, and also developing tools to help aid in the patient experience. So I'm really happy to be here with you today. Thank you so much for the time. So a little bit about Insight. So we're a global biopharmaceutical company, and we're headquartered in Wilmington, Delaware. Our mission is to solve on, which really means that we relentlessly follow the science to find solutions for patients who are dealing with critical unmet medical needs. And that's regardless of disease size or patient population. So I want to talk to you about 3 important things. The first is patient access to medicines. That's really critical. We want to make sure that patients can access the treatments that they are prescribed by their healthcare professionals, and that's very important to us. So our patient program is called Insight Cares. It offers insurance verification, prior authorization support, help with financial assistance programs for eligible patients, and treatment or condition education. That we can help also locate appropriate support services and programs if you need it. So we always recommend that patients enroll, even if you don't anticipate needing assistance immediately. We can, if you do at some point need assistance, we can help you much more quickly. And you can find that at insightcares.com. We spell it INCYTE cares.com. We're also enrolling in clinical trials. And so if you're interested in learning more about our clinical trials, of course, you always want to talk to your healthcare provider, but we have information about our clinical trials at insightclinicaltrials.com. And then patient community support is also really important to us. And most recently, something that we did was we launched a program called The Unseen Journey. It's an initiative that highlights the stories of people with MPNs. And what we've done is we're utilizing generative artificial intelligence imagery to help raise awareness about the common symptoms you may experience as an MPN patient. And this tool, where you can create your own symptom imagery, is now available to all patients to create your own symptom image if you like. They're attention grabbing. And the goal of this program is to really help others understand what that patient experience is like. So if you're interested in creating your own generative AI image of your symptom experience and downloading it to share with others, you can visit theunseenjourney.com. And with that, I'll wrap it up there. Thank you guys so much again for inviting me to discuss our passion and our work and our partnership. We appreciate you so much. And back to you, Anne.
And we appreciate you and your support. We would not be able to do any of this without the support of our partners. But also, I think it's very important that we hear from them and that our patients understand the work that they do. And also for the patients that need assistance in getting the drugs that are available to you right now, there are resources available to you as well. So we'll go now to Pharmacentia and Martin Blood, who's the medical science liaison. And Martin,
Hello.
thank you for joining us.
Thank you, Anne. Thank you for having me on, and I'll say hi to everyone. As she did just introduce me, I am one of the medical science liaisons for the company. And for you all, for what that means is I actually work with the physicians and researchers on both education and helping them decide on new trials and new ways to treat patients. So we work hand in hand to try to bring that information back to the company and create the trials that will bring drugs to the forefront that you can use for your therapies. So as for the company, I do work for Pharma Essentia. This is a global pharmaceutical company. It's headquartered in Taipei, Taiwan, but we do have a U.S. headquarters here in Burlington, Massachusetts. And in terms of what we're doing from a research standpoint, you did recently just heard Dr. Rampal talk about ET. So we do have 2 trials that just completed looking at our product Bezrimi used in ET, both one of them called the Surpass ET trial and the other Exceed trial. And with the information from both of those trials, we are suspecting to put through an FDA application for an indication later this year, beginning of next year. And hopefully that will be an indicated use for our product in the future. For our MF patients, we do have a trial that will be starting very shortly. It's called the HOPE PMF trial, and that is looking at patients with pre-fibrotic myelofibrosis. So within the United States, I believe that we're going to have about 20-25 different sites, and we're looking at that to be starting up in the next few months. So you'll be hearing about that at various other centers for pre-fibrotic MF patients. In terms of patient advocacy and such, we do have a program called SOURCE. You can find that information on our website at pharmaessentia.com, and that will bring you information in terms of what Anne was talking about, patient assistance programs and things like that. And I believe that's really what we have going on right now. And I wanted to thank Anne again for having us on here and being able to speak to you. And hopefully everyone, your journeys are successful.
Thank you, Martin. And did you change your name to Blood when you got that job?
No.
I know I love to tease you about that, but anyway, thank you very much.
Thank
And Pharmacentia has been a longtime partner with us, like Insight, and and we really appreciate your support. We'll move on now to Kartos and to Kimberly Price, who's the Executive Director of Medical Affairs and a thought leader engagement. And I've known Kimberly a long time as well. Kartos has been a great partner for years. And Kimberly, what do you have to share with us today? I know you've got some great stuff going on there.
Thank you, Anne and Natalie and Dr. Rampal, for this great meeting to educate patients on MPN diseases. So I'm very honored to have the opportunity to share an update on Kartos's POESIS study. So I work in medical affairs, as Anne mentioned, at Kartos, and it's a company developing a new medicine called navtemadlin. And navtemadlin belongs to a class of drugs called an MDM2 inhibitor. So how it works, our bodies have a natural tumor suppressing gene pathway or a protein called P53, which you heard from Dr. Rampal. So in healthy cells, P53 detects problems and can stop abnormal growing like myelofibrosis, malignant cells. So when this pathway, because of another protein called MDM2, which blocks that P53. When that happens, abnormal cells keep multiplying. So the idea is navtemadlin can inhibit that MDM2 to allow P53 to do its job. So navtemadlin is involved in the POESIS trial, and POESIS is currently enrolling for patients whose disease has a suboptimal response following treatment with a JAK inhibitor called ruxolitinib or Jakafi. A suboptimal response means that the following treatment from ruxolitinib or Jakafi, the spleen can remain enlarged and symptoms.
Oh.
There are no currently approved therapies in this setting, and that is why Kartos is doing the POSIS trial. It's a phase 3 recommended trial, and it's comparing the safety and efficacy of adding navtemadlin to Jakafi versus placebo to Jakafi. Participants have to be 18 and older, have a diagnosis of primary or secondary MF. But the thing that's most important is that they need to be enrolled to get their first. We can't figure out what a suboptimal response is without having that.
Just when
if you have
you,
any
just when you,
about,
excuse
please ask
me,
physicians.
Kimberly, just when you
Yes.
said what you need, you broke up terribly. So could you
Oh,
go
I
back about
apologize.
a half a minute?
Yeah, sorry about that. I'm on a hotel Wi-Fi.
Oh my
traveling.
gosh. It's breaking up a little bit.
So I hope that you can hear me okay now. I moved
Yes.
a little bit.
Yes.
So to enroll in POESIS, you can't have had a JAK inhibitor like Jakafi before. You have to be treatment naive
Okay.
to
And
Jakafi.
not, yes. Which means you have no treatment. Right.
No treatment with the JAK inhibitor.
Right.
The POESIS trial is enrolling in over 100 centers.
Wow.
And so you can reach out to Anne, Dr. Rampal, and many other physicians to get more information. There is a website called POESIS, POIESIS -trial.com to give you more information as well. Sorry about my Wi-Fi.
No, that's great. And the big thing with these clinical trials that for those listening is, you need to speak with your physician to see if you are a candidate. But clinical trials are what is so important for all diseases. And in the MPN space, we absolutely need to make sure that people are educated and the physicians are educated about what trials are available right now. Thank you so much, Kimberly. And so moving on to Joe Loers, who's from Silence Therapeutics, and he's the Senior Director and Medical Liaison. Hi, Joe.
Hi, Anne. Thank you for having us. So I am the Senior Director and Medical Science Liaison with Silence Therapeutics. Silence Therapeutics is a biotechnology company that was formed in 2005 and focuses on the discovery and development of novel molecules incorporating short interferon ribonucleic acid, or siRNAs, to inhibit the expression of specific target genes in hematology, cardiovascular, and rare diseases. Silence is based in London, England, with a U.S. office in Hoboken, New Jersey, and research labs in Berlin, Germany. There are over 120 scientists and research staff at Silence Therapeutics. Our vision is to transform people's lives around the world by silencing diseases through our precision engineered medicines and driving positive change for the communities around us, including people living or affected with polycythemia vera. We are proud to be a global and diverse company. So why are we called Silence Therapeutics? RNA interference involves the use of short interfering RNAs. siRNAs silences diseases by using the body's own natural mechanism. Our long-acting divesiran compound is an siRNA medication that is designed to reduce the production of TMPRSS6 in the liver, resulting in increased expression of your own natural hepcidin, which is the key regulator of iron homeostasis. By temporarily blocking or silencing this specific gene message, our technology aims to lower the hematocrit, reduce or eliminate phlebotomies, and reduce PV symptoms such as fatigue, brain fog, itchy skin, and lowering the risk of blood clots and strokes. Divesiran has the potential to positively impact blood diseases such as polycythemia vera. Silence Therapeutics is excited to announce our San Rico Phase 2 clinical study of our Divesiran treatment. We are currently seeking patients with polycythemia vera who are struggling with excessive phlebotomies or uncontrolled hematocrit levels and want to have a better quality of life. Our Phase 2 study is currently evaluating an every 6-week and an every 12-week sub-Q dosing. So if you've had 3 or more phlebotomies in the past 7 months or 5 or more phlebotomies in the past year, you may qualify for our Phase 2 study. All San Rico study sites are now open, and participants can enroll and take part here in North America. To learn more and find a location near you, please visit www.clinicaltrials.gov. We want to thank Anne, Natalie, and MPN Advocacy International for their wonderful work with these MPN specialists, MPN patients everywhere, and these terrific programs just like this one.
Thanks,
Anne.
Joe. Thanks, Joe. Gosh, I hope things work out with that drug because I know a lot of patients would benefit from that, definitely. But thank you all very, very much. And without keeping you on much longer, we just want to reiterate that we will be having more webinars coming up, one with Dr. Gertz, one with Dr. Elf, and you should be receiving our flyers and newsletter. Our in-person event, the 11th Annual Women in MPN program. And again, any of our in-person events, all of our webinars are free, but any of our in-person events, if you have a financial hardship and would like to attend, please let us know and you can come for free. But you need to let us know. Thank you so much and have a wonderful day. This is recorded and will be available to you in the next few days. Thank you.